Participants, listeners, ladies and gentlemen. On behalf of the Student Scientific Society of the Medical University of Silesia, I would like to thank you for coming and taking part in the International Medical Congress of Silesia 2025. My name is Jakub Fiedler-Rudol, and it is my pleasure to coordinate the session of internal medicine. We would like to explain the rules of the session before we start. The order of presentations will be the same as in the abstract books, apart from the change that the last presentation will be the first. The maximal time for each presentation is 7 minutes for presentation and 3 minutes for a discussion. If the presenter exceeds the time specified, he or she has to move on to the conclusions and present them as soon as possible. We will deduct points for exceeding this time. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper, you should refrain from assessing it. In the case that you do not cross this paper on your card, we will automatically ignore this. All presentations must be in English. We kindly ask the jury to assess the papers for scientific value from 1 to 5, way of presenting 1 to 5, a discussion 1 to 5, and own contribution of the students. It is advised that the students also mention their own contribution at the end of presenting the paper. When the session ends, we kindly ask you to give back the cards to me, the coordinator, or send the reports to the system. To begin with, I would like to invite the first presentation, which will be an online presentation titled The Correlation Between Oral Microbiota and Psoriasis Severity, a Retrospective Study. I would like to ask the presenter to share the presentation and start.
Good morning, hello. 1 second, everybody.
Hello, we can hear you. Can you hear us?
Yes, I can hear you. Can you hear me?
Yes.
Okay, perfect. And 1 second. I'm sharing the presentation. Is it now visible?
We can see your screen, but not the presentation.
Okay.
Station.
Sorry for the technical issues. Informatics is definitely not my best side. Okay. Now, is it visible?
Ewentualnie tak możemy. Ta pośrednia. Ta pośrednia? Niestety wydaje mi się, że to tylko się włącza i wyłącza i niestety nie możemy. Możemy tak zostawić ewentualnie? Z naszego punktu widzenia.
Okay, excuse me. So everything is visible, right?
Yes.
Okay, perfect. So once again, good morning. Hello, dear jury, dear colleagues. Today, I would like to present my study on correlation between oral microbiota and psoriasis severity as a retrospective analysis of oral swabs of patients with psoriasis and pharyngitis. My name is Karolina Jamrozik, and this is covered under the supervision of Student Scientific Association of Dermatology and Venerology of University of Warmia and Mazury in Olsztyn. To start with the simple things, what actually is psoriasis? This is a non-infectious, immune-mediated, multifactorial chronic inflammatory disease with skin and joint manifestations. It is caused by a combination of genetic predisposition and the influence of environmental factors, which include, among others, infections caused by the microorganisms such as bacteria, fungi, and viruses. And obviously, there are important factors triggering or the onset or the exacerbation of psoriasis. Our study analyzes presence of pharyngitis, also the type of microorganisms cultivated from oral swabs from the patients with pharyngitis, and assesses severity of symptoms with use of psoriasis area and severity index. The purpose of the study is to analyze the influence of several disease-causing microorganisms on the exacerbation of clinical manifestation of psoriasis. Materials and methods that we used in our study is that, as I said before, the oral swabs collected from the patients of the dermatology, sexually transmitted diseases, and clinical immunology in Olsztyn. The number of patients that took part in this study was 468. And also later with the swabs, we collected the data about the PASI index. The study included also an analysis of patients with consideration of their age, of their gender, presence of a psoriatic arthritis, as I said before, PASI, and presence of pharyngitis. Our study group consisted of 41% of women, which was 191, and 277 men, which was 59%. The pharyngitis symptoms were present in 42% of patients and no symptoms in the other 58%. Also, to divide it with the gender, pharyngitis was more prevalent in men because it was in 63% of men, while only in 36% of women. And now the severity of symptoms, the patients that took part in our study, the 58% of the patients had a PASI greater than 10, which is correlated to the moderate to severe onset of psoriasis, while 25% had a PASI lower, and also 70% of patients with psoriatic arthritis. And the prevalence of pharyngitis according to the severity of symptoms. That's again the percentage. Okay, and when we already know precisely our group, let's get down to the clue to the results of the study. The most common pathogen collected from the patients was Streptococcus viridans, which was present in 21% of patients with pharyngitis. The second one was Streptococcus pyogenes in 19% of patients. Later, the third one, Staphylococcus aureus, later Candida, and then all of the rest of microorganisms with significantly lower representation. And the correlation of microorganisms, the representation of microorganisms vary in a group of patients with different PASI, which we can see here. The presence of three most common pathogens are stronger marked in a group of patients with PASI greater than 10. Okay, and now one of the clues of the study, which is the summary of how the presence and the severity of symptoms were represented in a patients with infection and without it. So we can see that the amount of patients with moderate and severe course of the disease, which is PASI greater than 10, is larger among the group with pharyngitis than among the patients with no infection. And this is as far as 10% different in a distribution of a group with mild course disease comparing to the group with severe course. Okay. So getting now to the conclusions, the most common pathogen collected from the patients was Streptococcus viridans, and on the second place, Streptococcus pyogenes, which in summary is telling us that streptococcal infections marked the stronger presence during the exacerbations, and that correlated with the acuteness of clinical manifestation. Microorganisms infections on the upper respiratory tract may be an important factor in provoking enhancement of psoriasis. And what is this whole study leading us is the fact that it indicates the need to perform oral swabs in order to eliminate factors causing exacerbation of symptoms among patients with psoriasis, which may be important in the treatment of the disease. Okay, and finally, those are some of the resources that I used during making the presentation. And once again, thank you very much for your attention. Thank you so much.
Thank you very much for your presentation. I would like to now proceed with the discussion. Are there any questions from the jury?
Thank you for your presentation. It was a very interesting study. I understand that it was a retrospective study. You analyzed the protocol and analysis of patients, yes? And
yes.
My first question is connected with the question. It was a carrier of bacteria or acute infection, pharyngitis? In the treated group.
Okay, so we did it as the carrier of the bacteria, but we also evaluated the presence of pharyngitis because it is known that infection itself, being sick, is a factor triggering autoimmune diseases. So for that reason, we also wanted to check among the patients with with no pharyngitis, what is the microbiota like?
And my second question is if you analyze also the interaction between this infection and PASI score and interleukin 23 and lymphocyte TH17, which are the important in psoriasis.
We only analyzed the main thing that we analyzed to assess the severity of the disease at that present time was the PASI index, as it was relatively cheap and easy source to use to assess that present severity of the disease.
Maybe it will be interesting and objective also information about the psoriasis and connection with the infection. And my last question is if you also analyzed maybe the use of antibiotics, targeted antibiotics, and the influence of this treatment procedure for severity of psoriasis.
Mm-hmm. Yes, that is also the part of our interest, which we would like to evaluate as a further study. But for that, it was kind of a baseline to also know the microbiota, the most frequent organisms, and we would also like to conduct a study that correlates the use of medications in the patients to the microbiota. But for that given moment, we don't have the results of that study yet.
Thank you very much. And congratulations for the presentation.
Tak, ponieważ była sugestia organizatorów, żeby prowadzić dyskusję w języku polskim, no to żeby ułatwić Pani drugą część tych pytań zadam po polsku. Dwa krótkie pytania. Jedno, czy Pani oceniała statystycznie te różnice wartości, częstości występowania wysokich i niskich wskaźników PASI w tych poszczególnych grupach z infekcją? Procentowe różnice, tak patrzą między 53 a 62%, no to dyskusyjny temat, czy to jest różnica zestawienna statystycznie, czy jakąkolwiek statystykę taką.
Na potrzeby tej prezentacji nie została przeprowadzona statystyka. Też wydaje mi się, że po to, żeby otrzymać faktycznie takie wyniki statystycznie znaczące, to musimy nadal kontynuować to badanie, co zresztą robimy w takim celu, żeby tych pacjentów było więcej, dlatego że grupa, która miała tylko 468 pacjentów, kiedy podzielimy to w zależności od tego indeksu PASI, w zależności od mikroorganizmów wywołujących infekcje, to niestety nie są jeszcze duże grupy, natomiast jesteśmy w trakcie ewaluacji dalszej kontroli pacjentów, dlatego mam nadzieję, że być może w przyszłym roku na konferencji już będę mogła coś statystycznie bardziej znaczącego zaprezentować.
No to jeżeli tak, to proszę potraktować to ostatnie pytanie w kategoriach rady, bo jeżeli we wnioskach sugeruje Pani, że szczególnie jeden typ patogenu dawał znaczący wzrost, nazwijmy to, wskaźników ciężkości choroby, to warto byłoby wyliczyć średnią wartość wskaźnika PASI dla każdego patogenu. Tego tu nie było, a tylko wtedy mogłaby Pani obiektywnie powiedzieć, że jeden z patogenów wywoływał dużo bardziej ciężkie objawy niż inny. Sama częstość patogenu w grupie o większym lub mniejszym poziomie wskaźnika PASI nic o tym nie mówi. To taka rada do tej naszej analizy.
Dobrze, oczywiście, bardzo dziękuję. Dziękuję bardzo.
Thank you.
Thank you very much. Does the doctor who is online with us have any questions?
jedno logistyczne, bo mamy taki punkt oceny wkładu własnego. Chciałaby Pani powiedzieć, na czym polegał wkład Pani własny w przygotowaniu tej pracy?
Dobrze, zatem elementem mojego przygotowania pracy było właśnie zbieranie wszystkich danych od pacjentów, to znaczy ocena wskaźników pasji, a także zbieranie wszystkich danych w celu przygotowania bazy dotyczących mikroorganizmów i także ewaluacja z innymi pracami przygotowywanymi w podobnym temacie. Tak.
Procentowo, jak mogłaby Pani określić swój udział w tej pracy?
Przepraszam, nie usłyszałam pytania.
Procentowo, jaki by Pani mogła określić swój udział w tej pracy?
Myślę, że jako 65%, dlatego że mimo, że było to czasowo bardzo duża ilość pracy, no to, że tak powiem, cały zamysł pracy i tego badania nie był mój własny, natomiast był dziełem opiekunki pani tutor Joanny Czerwińskiej, która zaplanowała całe to badanie, a że tak powiem, część techniczna stała po mojej stronie.
Ale to i tak wysoki. Gratulujemy, bo duży wkład pracy.
Dziękuję bardzo.
Thank you. Thank you very much for the presentation.
Dziękuję. Ja chciałam tylko pogratulować. Bardzo ciekawa praca, więc myślę, że jeżeli zostanie rozbudowana o dalszą analizę danych, to na pewno może zostać opublikowana w jakimś wartościowym czasopiśmie. Także dziękuję za prezentację.
Dziękuję bardzo.
Thank you very much for the presentation. We would like to invite the authors of the second presentation titled Hypoxia and Metabolic Dysregulation in OSA, HIF-1 Signaling and Insulin Resistance. This is an online presentation, so we'd like to ask for authors to share the presentation with us. Are the authors on the meeting? It seems that the authors have not joined the meeting, so we will continue with the third presentation titled Tailoring Treatment Impact of Comorbidities on Dulipumab Efficacy in Severe Asthma.
Good morning, esteemed jury, fellow participants, session coordinators, and viewers as well. My name is Julia Szlączek, and I'm presenting the work conducted with my colleagues Marta Turek and Michał Porada in the Department of Pulmonology at Medical University of Silesia under the supervision of Dr. Małgorzata Parnik, titled Tailored Treatment, Impact of Comorbidities on Dulipumab Efficacy in Severe Asthma. Asthma is a heterogeneous inflammatory disease affecting millions globally. Once someone develops asthma, their quality of life falters. With this comes biological therapy as one of the last resorts for a normal quality of life. Biologic therapies are a major advancement in severe asthma, especially for patients unresponsive to the standard therapy. The key options in Poland include omalizumab against immunoglobulin E, mepolizumab and benralizumab, which both target interleukin-5, tezepelumab, and our focus dupilumab, which targets interleukin-4 and interleukin-13 pathways, which is crucial in type 2 inflammation, and dupilumab has been accepted for treatment in 2023 in Poland. Dupilumab is a human IgG4 monoclonal antibody approved for treating moderate to severe asthma, atopic dermatitis, and chronic rhinosinusitis with nasal polyps. It inhibits interleukin-4 and interleukin-13 signaling, modulating the Th2-driven inflammation. The clinical trials have demonstrated that the efficacy for severe asthma in terms of dupilumab is approximately 72 to 76%. But for us, we wanted to see in real-world settings whether it has any impact, because we have two doses of dupilumab, 200 milligrams and 300 milligrams. The 300 milligram being the one that is mostly given to people with the comorbidities that I listed beforehand. So we wanted to see if that actually has any impact on their response. Our study set out to answer the question that clinicians in our clinic face. Does the presence of comorbidities influence the effectiveness of dupilumab in treating severe asthma? The hypothesis was that most probably the coexisting conditions such as nasal polyps or allergies might benefit more from a higher dosing and tailored therapy. We studied 24 patients because the qualification for biological therapy is not as easy as it seems, between 2023 and 2025 at the Medical University of Silesia. All of those patients have completed at least one control checkpoint, which is when 6 months of therapy has been already done. And we evaluated the asthma quality of life questionnaire, the asthma control questionnaire, the reduction in exacerbations, systemic glucocorticoid use, the global evaluation of treatment effectiveness response, and adverse effects that the patients might have developed. The cohort included 8 men and 16 women. The age being between 31 and 80 years old. The mean age was 54. It's worth noting that there was a high eosinophil count that was observed, averaging 560 cells per microliter. And this indicates that there was a type 2 high asthma population, which is the asthma phenotype that dupilumab is targeting. These patients often represent a subgroup in terms of nasal polyps, because as we can see on the next slide, we have 30 persons that have nasal polyps in total. I think maybe there is a mistake on my table, but there was 13 with nasal polyps. And these patients often represent a subgroup with more systemic type 2 inflammation. And their improvement may partly explain the better response to the 300 milligram dose. 10 had allergies, which are coexistent with common comorbidities and severe asthma overall. And these multi-organ symptoms justify the use of higher dose of dupilumab. The improvements here are both statistically and clinically significant. Those are the mean ACQ and AQOQ values in terms of the 200 milligram dose, the 300 milligram dose, and in comparison to the overall population. For context, in terms of ACQ and AQOQ, we need at least 0.5 point change to make sure that the treatment is actually effective. And all patients exceeded this threshold, the 300 milligram group being not only surpassed it, but showed changes approximately 4 to 5 in terms of GETA scale, because the scale is 1 to 5. So they received all very high scores, and no one was excluded from the therapy due to any adverse effects. And let's look also at the worsening of those symptoms. So here we have a comparison of comorbidity effect on response. And in total, what is important, the 200 milligram group, in terms of asthma quality of life, improved by 2.02 points. So 4 times what we wanted, with the 0.5 being our actual value, while the 300 milligram group saw an even larger improvement with plus 2.6 for AQOQ. For asthma quality control questionnaire, we want the score to decrease by at least 0.5. So if we look at the 200 milligram group, it improved by minus 179, and for the 300, it improved by negative 2.32. So there were significant, at least 4 times better than what we would want. And overall, another observation is that the baseline AQOQ and ACQ for 300 milligram dose were worse at the start, suggesting that those patients have a higher disease burden at the onset. And in conclusion, what is important is that dupilumab proved both effective and safe in treating severe asthma in a real-world setting. The patients with comorbidities, particularly nasal polyps and allergies, showed even greater improvement, especially with a higher 300 milligram dose. These results highlight the importance of personalizing biological therapy, because what I didn't mention during the presentation is that some of the patients, 5 of those 24, had previously had other biological therapy that was proved ineffective for them. And they were now treated with dupilumab, and now they have actually responded to this monoclonal antibody. And overall, the absence of the adverse effects, we measured those by calling each patient and asking whether they have any adverse effects right after or 1 week later after they have been admitted in hospital where they received a dupilumab injection subcutaneously. And no one has shown any adverse effects, and they were all very happy that they received this treatment. So overall, the study really reinforces the role of tailored therapy that we noticed with monoclonal antibodies in terms of asthma. And that is all that I wanted to say. And one more thing, because I think this didn't change really. But in the conclusion, I had that the failure of treatment, because 5 patients failed previous biological therapy, but we didn't exclude them when we received the okay for dupilumab in our department. So going forward, larger studies, obviously, because this is 24, this is a little less than what I would want, could help in actually identifying the dosing strategies for dupilumab and maybe biological therapy in asthma. Thank you for your attention.
Thank you very much for your presentation. We will now proceed with the discussions.
Gratuluję Pani pracy, bardzo piękna. Mam jedno pytanie. Jak długi był okres obserwacji tych chorych? Ponieważ wiemy, że tutaj bardzo często może dochodzić do nawrotów prowokowanych przez czynniki alergiczne. Jak długi był czas obserwacji? Czy rzeczywiście ten efekt, który Państwo zaobserwowaliście, zdecydowanie lepszy niż w poprzednich badaniach klinicznych, jeśli potwierdził długofalowej obserwacji pacjentów?
Tak, na razie większość pacjentów, bo była kwalifikacja pierwsza, zaraz po zakwalifikowaniu dupilumabu do programu lekowego, do NFZ-u, i wszyscy ci pacjenci, 14 już 1,5 roku się leczy, więc my cały czas patrzymy, jak się zmieniają te dane, natomiast żeby tutaj było wszystko równo, to wzięliśmy tylko osoby, które przeszły już te pół roku leczenia, więc jakby to jest takie wstępna ocena tej odpowiedzi, natomiast są też osoby, które już rok się leczą i przeszły 3 punkty kontrolne i nagle ta odpowiedź zostaje taka sama.
A czy badacie Państwo też jakieś obiektywne wskaźniki, jeśli chodzi o astmę? No bo tutaj dupilumab działa na interleukinę 4., 13, czy też są takie badania obiektywne?
Znaczy interleukiny bezpośrednio niestety nie mierzymy. Myślę, że budżet mógłby nie wytrzymać. Natomiast robimy spirometrię, więc patrzymy też na zmiany w spirometrii, czy faktycznie first explanatory
nie obserwacja kliniczna i badania spirometrii.
Dokładnie. Dziękuję za kwestionariusz, który jest zvalidowany kwestionariuszem do objawów astmy.
Dziękuję bardzo.
Gratuluję, bardzo ciekawa praca, pięknie zaprezentowana. Natomiast ja mam takie jedno zastrzeżenie co do metodyki. Bardzo istotne. Ponieważ tytuł pracy ocena wpływu współistniejących schorzeń na efekt działania leku na zaostrzenie czy tam na stopień patologii przebiegu astmy. Natomiast Państwo w obu grupach macie różną dawkę leku. I teraz pytanie, czy ten lepszy efekt w grupie ze współistniejącymi schorzeniami wynika z tego, że może te współistniejące schorzenia powodują to, że można uzyskać tam lepsze elementy poprawy, czy też wpływało na to tylko i wyłącznie dawka leków. Moim zdaniem idealne byłoby badanie, gdyby w obu grupach stosowano tą samą dawkę leków. Wtedy by autentycznie można porównać, czy te współistniejące choroby miały jakiś wpływ na efektywność tego preparatu. Skąd pomysł, żeby dać 2 różne dawki?
To znaczy tak jest niestety w wytycznych kwalifikacji i jak pacjent ma jakieś choroby właśnie polipy nosa, zapalenie zapach przewlekłe, to musimy dać mu 300 mg.
Tak, zgodzi się Pani.
Tak, zgadzam się.
Że danie tej samej dawki dopiero wtedy można by realnie ocenić, czy na efekt leków miały wpływ współistniejące schorzenia, a nie sama dawka leków. ale rozumiem, że pacjentów Państwo mieli niejako z urzędu w ramach programu. No i tradycyjne pytanie, jak Pan nie ocenia swój wkład własny w wykonanie tego badania?
Myślę, że zacznę z tego, że na oddziale się śmieją niektórzy rezydenci, że nie mam co robić, bo cały czas tam jestem. Natomiast temat wymyśliła moja pani doktor pani. Natomiast ja zebrałam wszystkie dane z systemu, rozmawiałam z pacjentami, dzwoniłam do pacjentów, byłam też w trakcie punktów kontrolnych, żeby zadawać im pytania i potem te wszystkie dane opracowałam statystycznie i przygotowałam prezentację.
A to dziękuję.
Thank you. Are there any other questions from the online jury?
Tak,
If there are no questions, then we will proceed to the next presentation. And I'd like to invite the authors of the next presentation titled The Correlation of TSH Levels with Inflammatory Markers in COVID-19 Patients, a Retrospective Study.
Good morning, ladies and gentlemen. My name is Dr. Katowice, and I'm honored to share with you the results of our study regarding the correlation of TSH levels with inflammatory markers in COVID-19 patients. And the SARS-CoV-2 can cause a severe inflammatory response that may lead to a multi-organ failure and death. And this systemic illness may affect the hypothalamic pituitary thyroid axis, lead to a decreased TSH level. Thyroid stimulating hormone is essential for thyroid function and may reflect the patient's overall condition. And there are clinical observations that suggest that there is a link between the low TSH level and more severe COVID-19 outcomes. But the relationship of TSH level and inflammatory markers remains unclear, and we wanted to have our part in discovering the relationship between TSH and inflammatory markers. I would like to start with mentioning the two potential mechanisms through which the COVID-19 may affect the hypothalamic pituitary thyroid axis. And the first of them is the angiotensin converting enzyme 2, which is expressed in pituitary gland and thyroid gland. And this enzyme is a gateway for SARS-CoV-2 to infect our cells. Apart from the virus itself, the inflammatory response of our organism may affect the hypothalamus and the thyroid gland as well. And our aim was to evaluate the correlation between TSH level and inflammatory markers in hospitalized COVID-19 patients. So we conducted a retrospective study of 105 patients admitted to the University Clinical Center in Katowice from 2020 to 2023, who were tested positive for COVID-19 with a PCR test. And we evaluated the following parameters. We evaluated TSH level, platelet count, C-reactive protein level, D-dimer level, procalcitonin level, lymphocyte count, lymphocyte percentage, and neutrophil to lymphocyte rate. Our exclusion criteria were as follows. It was no TSH assessment and history of thyroid dysfunction. And out of 456 patients admitted and tested positive for COVID-19, 251 of them didn't have their TSH assessed. And from the remaining 205 patients, 100 had a history of thyroid dysfunction, and the remaining 105 patients were excluded in our study. 52.7% of our population was male, and the age distribution varied from 24 to 95 years. Cutting to the chase, the lymphocyte count has shown a positive correlation with the TSH level, which is visible on the graph on the right. And it means that with the increase of the lymphocyte count, we observe also an increase in the TSH level. We have carried out a quantile regression for the lymphocyte count, and it has shown that with the increase of the TSH level, we observe a stronger relationship of it with the lymphocyte count. On the other hand, the neutrophil to lymphocyte rate has shown a negative correlation with TSH level. So with the decrease in the TSH, we observed an increase in the NLR. When it comes to the platelet count, we haven't observed any correlation in the whole group, but in the female population, we observed a positive correlation, and that meant that with the increase of the platelet count, the TSH level was also increasing. Other evaluated parameters didn't show any correlation with the TSH level. To sum up, the TSH level has shown a positive correlation with lymphocyte count and negative with NLR, and in the whole group, and with platelet count in the female population. So it might suggest that TSH level has a potential as a biomarker in disease severity in the corresponding groups, and other indicators didn't show that correlation, so maybe other indicators should be considered. We are aware of our study's limitations, which were small sample size, incomplete data, and most importantly, lack of free thyroxine and free triiodothyronine, and no follow-up period. And thank you very much for your attention, and I invite you for the discussion.
Thank you very much, and we will proceed with the discussion.
Dziękuję kolego. No, ciekawa praca, była bardzo ładna prezentacja. Natomiast mam takie dwa pytania. Pierwsze, które się chyba narzuca. Dlaczego Pana zdaniem te płytki wykazywały korelację kobiet, a nie u mężczyzn? Czy ma Pan jakąś tutaj koncepcję?
I ja mam koncepcję taką, że to wynika po prostu z za małej ilości danych, że na przykład u kobiet to akurat takie dane wyszły, że ta korelacja była. W zasadzie wśród wszystkich parametrów, które nam nie wyszły, ta korelacja mogła nam iść, jakby mogłaby nam wyjść, gdybyśmy mieli po prostu więcej pacjentów. Niestety nie udało nam się już więcej tutaj z tego szpitala zebrać i myślę, że to tak.
Rozumiem, no bo szczęśliwie mieli Państwo prawie po 50% obie płci, bo gdyby była duża różnica procentowa, no to tłumaczenie byłoby bardzo racjonalne. Czy taki rodzaj rozkładu mamy? Ale jest to jakaś koncepcja. Natomiast drugie pytanie, no w tych ograniczeniach pracy wspomina Pan o braku oznaczenia czynnych hormonów tarczycy. No wydaje się rzeczywiście, że to dużo bardziej wartościowy wskaźnik. Rozumiem, że rutynowo u pacjentów na udziale oznacza się państwa, a tylko w wybranych przypadkach czy też taktowu.
Tak, najwięcej też tych pomiarów FT3 i FT4 było pacjentów, którzy mieli chorobę tarczycy w wywiadzie, no więc mieli kluczali.
No rozumiem. Dziękuję bardzo.
Dziękuję.
Ja mam pytanie, na ile byłby te hormony tarczycy TSH byłby wskaźnikiem ciężkości stanu pacjenta? Czy można zaryzykować stwierdzenie, że to marker ciężkości przebiegu infekcji?
Wydaje mi się, że można by było to TSH na pewno wziąć pod uwagę, ale też chcielibyśmy oznaczać te hormony właśnie w samej tarczycy, dlatego że chociażby zespół niskiej trójiodotyroniny, który nam sugeruje, że silna odpowiedzialna organizmu powoduje zmniejszenie zarówno tam TSH, jak i hormonu tarczycy, świadczy o ciężkości choroby, więc wydaje mi się, że jako samo to TSH nie może być wskaźnikiem ciężkości choroby, natomiast jeżeli mamy pacjenta, który nie ma w wywiadzie choroby tarczycy, a ma niskie TSH w wyniku właśnie pobytu w szpitalu, czy infekcji, która na przykład się trafiła, to wydaje mi się, że mogłoby to sugerować, że taki pacjent jest po prostu w cięższym stanie niż to TSH było w normie.
I drugie pytanie dotyczy ewentualnego wpływu zakażenia SARS-CoV na rozwój zapaleń tarczycy, ponieważ możemy to interpretować dwojako. Wiadomo, że TSH i tarczyca reaguje w ciężkich infekcjach, ciężkich zakażeniach, jak również w ciężkich chorobach. Wtedy poziom tych hormonów jest zaburzony, ale równie dobrze można by było ewentualnie spekulować, na ile zakażenie COVID również nie rozwija autoimmunologicznych zapaleń tarczycy. Czy miałby Pan tu jakąś sugestię na podstawie wykonanej analizy pacjentów?
Tak, znaczy